Okay, thank you for the question. So we perform a randomized clinical trial, which is called the HypoECMO study, which investigated the role of hypothermia in VI ECMO patients. It's a nationwide study. We randomize 260 patients in two groups, hypothermia versus normothermia. Normothermia was and hypothermia was induced through the heat exchanger of the ECMO device. We included patients with very severe cardiac shock, only intubated patients with cardiac shock within the first 6 hours of the ECMO. The patient were randomized to normothermia or hypothermia. The main endpoint was mortality at 30 days. And we also have some secondary endpoints. So there is, I think, 3 main results. The first one is that hypothermia is it's very easy to induce hypothermia with the ECMO exchanger. So we were able to decrease temperature, to maintain the temperature during 24 hours, to increase it slowly, and to maintain the normothermia for a total duration of 92 hours. The second result is that hypothermia is safe, and we did not find any differences for severe bleeding or for infectious events. And the third result is that, unfortunately, the P was 0.07, and there is some potential advantages for hypothermia. Mortality was 32% is the group for hypothermia versus 51%, so 9% of differences, which is not statistically significant. And we also perform a post-Bayesian analysis, which is in favor of hypothermia. So the conclusion for this study was that hypothermia in patients with very severe cardiac shock treated with VI ECMO is safe. It's not expensive. We did not find any differences for severe events. We found some tendency to have an improved prognosis. So my personal position is that in the inclusion criteria of the study and the non-inclusion criteria, we have to use hypothermia in these patients.